organizing such a historic gathering in a very historic place in Egypt, and for inviting me to show you some experience in the management of ischemic diabetic foods. We know that interventional procedures in diabetic food management are aiming at saving the patient's limbs. In other words, to prevent major amputation, and this is why we call them limb salvage procedures. Sometimes, in certain situations, one has to choose between saving the patient's limb or saving his life. And for sure, this is a real challenge. And definitely saving both is a great achievement. So in order to clarify this, let me show you this case. Male patient, 67 years old, diabetic, hypertensive, with ischemic heart disease. And he presented to me with an ischemic diabetic foot with gas gangrene involving the forefoot, with swollen dorsal spreading of infection, reaching to the lower anterior compartment of the leg. Of course, with absent pedal pulsations because it's an ischemic foot, and the patient has marked systemic septic manifestations with renal impairment and mental confusion. So it's obvious that the patient mandates an emergency intervention. So we asked for an anesthetic consultation, and they asked for a high-risk consent and for preparation of post-operative ICU. So we get back to the patient's family, and after discussing the situation with them, they accepted to provide the patient every opportunity possible and to, meanwhile, exert every effort to save the patient's limb, and of course to save his life. So after initial emergency resuscitation by our anesthetic team, we took the patient to the operating theater, and under spinal epidural anesthesia, we did an extensive foot debridement, as you can see here, because the tissues, the infection involved the whole layers of the foot. And you can see, you can appreciate here that what's remaining in the foot is very questionable if this foot is going to be saved or not. Afterwards, in the post-operative course, unfortunately, in the ICU, second post-operative day, the patient developed an ischemic stroke in the form of weakness at the contralateral healthy limb. And we asked for neurological consultation and carotid duplex evaluation, and they recommended medical therapy, which was initiated immediately. In the post-operative course, a few days later, the patient's general condition has been stabilized in the form of improvement of the vital parameters, and the septic status has been waived. So we started to have wound care of the patient with the aim of control of the wound condition with moist wound healing strategy, and in order to maintain viability of the tissues of the foot. And because this foot now is the functionally precious limb. These some photos that can express the early post-operative period of the patient. Again, it's now obvious that the tissues are markedly ischemic and with patches of gangrene at the edges and re-establishment of the necrotic tissues at the surfaces of the wounds. So it's an ischemic diabetic foot with an ischemic tissues everywhere. Then it's very important to revascularize the patient's limb. So we took the patient again to the angio suite, and you can now appreciate that there is extensive tibial vessel disease, and there is hopeful posterior tibial artery exactly at just above the ankle joint that, So we started endovascular revascularization with the aim of restoration of direct blood flow to the foot Here, the blood supply of the foot. Just would like to remind everyone that according to angiosomal concept, in other words, the territorial blood supply of our lesion, we have to tackle the posterior tibial and peroneal artery if possible. So we targeted the posterior tibial artery here, and after attempt at endovascular revascularization, we fortunately succeeded to disobliterate the posterior tibial artery. So 2 or 3 weeks after angioplasty, the patient developed very healthy granulation tissue, and the ischemic stump is now obvious that it's amenable for a sort of foot reconstruction. And then the patient was discharged from the hospital and maintained on best medical treatment for peripheral arterial disease. And now we started negative pressure wound therapy. After 2 or 3 weeks of negative pressure wound therapy, the patient developed a very healthy stump that can accept a sort of skin coverage, but the patient refused the skin coverage, so we continued on a negative pressure wound therapy until we reached this result. Do we have enough time? So in other words, Mr. Chairman, dear colleagues, ladies and gentlemen, to take home message, knowledge, the power, but enthusiasm pulled the switch. So welcome to enthusiasm. Thank you very much.
Thank you.